Welcome, everybody, to the almost last session now of the World Health Summit. For us, I'll be honest, don't tell anybody else out there, this is the best session of the meeting. It's the most exciting session for us, I must tell you, at the Lancet. We like to see new research data being presented because it's new evidence that begins to change hearts and minds and can provide the platform for advocacy and for policy change and for transformation around a whole area of political, social, and economic dimensions. So we need more data at the World Health Summit to inform the dialogues that take place. And that's why this session is so important. And the posters that you've seen around the meeting too. Very pleased indeed to have our presenters here. I'm very pleased particularly to be a partner with the World Health Summit in producing this abstract book. Now, what we're going to do today is we're going to hear 5 fantastic presenters and their data, which have gone through a process of review, and they won to get their presentations here to present orally to the meeting. 4 of the presenters are here. 1 of them is not here, and that's why I'm going to stand here and tell you about his presentation. The first presentation, as you'll see from the booklet, is this one here, Catastrophic Health Expenditure and Entitlement to Health Services in the Occupied Palestinian Territory. The author of this work, Majdi Ashur, who works for the United Nations Relief and Works Agency, and he's based in Gaza, is a very good friend of mine. Over the last 4 or 5 years, The Lancet has had a program of work working with colleagues in both Gaza, the West Bank, and East Jerusalem, really trying to build a kind of capacity in public health and clinical research so that the people living in the occupied territory can create the evidence themselves that can then inform the decision makers, both in the Palestinian Authority, but also regionally and globally, to help make better decisions for the health of the Palestinian people. And Majdi, we've been running, we ran a series 5 years ago on the occupied territory, and over the last 4 or 5 years, every year in March, we have an abstract-driven research conference which we hold in the region. This year it was held in Beirut. We've held it in the past in Cairo and in Ramallah and Jerusalem. So our goal is to try and build capacity. And Majdi has had many abstracts presented at those meetings, and it was great to see that he submitted work for this one. He's not been able to be here because it's not easy to leave Gaza, and he was denied permission, I believe, to leave the Strip and unable to get a visa to come here today. What I'm going to do, though, is he's very kindly provided words. So I'm not going to give my interpretation of his work. I'm going to read you his words about his own work. So please bear with me. So you can see the title. I've already read it out. So catastrophic health expenditure occurs when people have to pay fees or co-payments for healthcare in high amounts compared to their own income. And that results in financial catastrophe for individuals or their households and leads them to cut down on the necessities that they require, such as food, clothing, or their children's education, or even healthcare. Like other societies, the Palestinian society in the occupied territory is a composite one with different socioeconomic groups and diverse categories within them. The political and historical events during the last 6 decades have shaped the Palestinian health system in a unique way, which made it to evolve in a highly fragmented manner, to include 4 main service providers: the Ministry of Health, the United Nations Relief and Works Agency for Palestinian Refugees, which is called UNRWA, non-governmental organisations and private for-profit providers. The first two of those health service providers, Ministry of Health and UNRWA, deliver health care to people entitled to those services. UNRWA provides care free of charge, primary health care services, and also subsidies to selected hospital services, which are given exclusively to refugees. Children who are under 3 years of age, pregnant women, and those who are enrolled in the government health insurance plan are eligible to receive the services offered by the Ministry of Health based on a nominal user fee. The refugee status of refugees does not prohibit their entitlements to the Ministry of Health services, and so the availability of two major health coverage plans from the Ministry of Health and UNRWA results in a dual entitlement of a sizable proportion to the population, especially in the Gaza Strip, which consists of about 70% of refugees. But despite all these different categories of the population in the occupied Palestinian territory, according to their entitlement to health services and categories, there's no knowledge at all about the difference in the occurrence of catastrophic health expenditure among those different groups of the population. So we, Majdi, explored in this research the differences between various categories in households of the occupied territory. So, methodology. Majdi analysed data from the Palestinian Consumption and Expenditure Survey, which was collected by the Palestinian Central Bureau of Statistics from January 2010 to January 2011. And the survey asked detailed questions about household expenditure, including spending on health. According to the World Health Organization adopted methodology, Majdi's team considered households with health payments catastrophic if those payments were greater than or equal to 40% of their non-food expenditures. And socioeconomic and demographic categories of the households, enrollment in health insurance schemes, and individual characteristics of the family head were grouped, and comparisons of catastrophic health expenditure occurrence were made among different categorical variables, and the analysis was done using chi-squared tests. Okay, so let's look at some results. Now, I'm going to let you just absorb that table, and I'm going to read the text that goes with the table, so follow carefully. Out of 3,754 households included in our analysis, 42.9% were headed by a refugee. Two-thirds, 67% of the households in the Gaza Strip were refugees, while only 31.6% of the West Bank families are refugees who are entitled to UNRWA health services free of charge. 2,109 families were enrolled in the government health insurance plan. That's 56%. 84% of the Gaza Strip sample were enrolled, and 43% of the West Bank sample were enrolled. A third, just over 37%, were considered poor or worse off, according to spending 45% or more of their expenditure on food items. The proportion of worse off households in the Gaza Strip was 52.5%, while that figure was 30.8% in the West Bank. Catastrophic health expenditure occurred in 90 households, which was 2.4% of the total number of households studied. And the occurrence of catastrophic health expenditure in rural areas of the occupied territories was higher than for those living in urban areas and in refugee camps, but that was not a statistically significant finding. The rate was higher in the West Bank compared with Gaza Strip. 2.7% of West Bank households face financial catastrophe due to ill health, while 1.6% in the Gaza Strip faced financial catastrophe, and that was significant, at P being equal to 0.032. another complicated slide. Follow carefully. Households that are categorized as worse off as a result of spending 45% or more of their expenditure on food experience catastrophic health expenditure at a rate of 1.7%, while those that were categorized as better off experienced catastrophic health expenditure at a rate of 2.8%, and that difference was statistically significant. When we looked at the vulnerability, when Majdi looked at the vulnerability of households from another angle, he found that households that were headed by women experienced catastrophic health expenditure much more than those led by men. 6.6% versus 1.9%, and that was very statistically significant. Households which were led by family members who were outside the workforce experienced health payment financial catastrophe rates of 5.1%. Again, statistically different from those who were led by unemployed or employed family members. That's even more complicated, that slide. Here, on this slide, Majdi is trying to present the difference of the catastrophic health expenditure occurrence according to the entitlement to health care services. Refugees face financial catastrophe due to ill health and payments for health care less than non-refugee households, but that difference was without statistical significance. The difference was statistically significant between enrollees in the government health insurance plan and those households who were not enrolled in it. Households who were insured faced financial catastrophe at a rate of 1.8%, while those who were not insured faced catastrophe at a rate of 3.2%. The different categories of households, according to their enrollment in the two available health plans, exhibited a difference in the occurrence of catastrophic health expenditure. Again, that was statistically significant. Refugees who are enrolled in the government insurance plan are those who are entitled to the services of both the Ministry of Health and UNRWA, and they were less exposed to catastrophic health expenditure than others. Those who were not refugees and who were enrolled in the government health insurance plan had higher rates of catastrophic health expenditures. Okay, interpretation of results. The results of the analysed data show that the catastrophic health expenditure amongst Palestinian households in the occupied territory is increasing from 1.1% in 1998, 2.1% in 2007, to 2.4% in 2010. There's a difference in its occurrence in different places in the occupied territory, where Gaza has a lower rate than the West Bank. And that's a paradoxical observation. But it can be attributed to the higher proportion of refugees in the Gaza Strip who are entitled to free UNRWA health services, and to the higher percentage of households enrolled in the government insurance plan, which was extended to include poor families after the outbreak of violence and collective punishment and closure and policies stopping people from moving around, which led to depriving Palestinian workers of exiting the occupied territory for employment. Now, there are different possible explanations for the results that indicate that poor people, according to their food expenditure, are more protected from financial catastrophe. The first is that the positive effect of expanding government health insurance to people who are affected by decreased economic output as a result of the 2000 Intifada. The second possible explanation is that privileged households afford the expenses of private providers and use them, while the deprived ones cannot afford them, and so go for public services from the Ministry of Health and UNRWA, making public services mostly for the poor and private services mostly for the rich. The results show that entitlement and double entitlement to health coverage plans had minimized the occurrence of catastrophic health expenditure, that's having the UNRWA and the Ministry of Health coverage. This protective effect of entitlement to health services offered to refugees through the United Nations Relief and Work Agency and to insured people through the government health plan suggests that any effort to decrease catastrophic health expenditure in the occupied Palestinian territory requires expanding the entitlement to health care to achieve universal health coverage. Thank you, Majdi, for that presentation. I'm going to clap him. Those are his words. So I'm very sorry that he wasn't here to present that himself, and you're not allowed to ask me questions because they're his data. But I hope that you will... I will send warm regards from Majdi, from you, the audience, back to him for coming to this session and for being present at his talk. Now, as you can see, I've got two colleagues on stage, Dr. Sabine Kleinert and Dr. Matthias Bonk, who are co-leading this symposium. But I'm going to introduce the next speaker, and then I'll hand over both to Sabine and Matthias. Our next speaker is Dr. Vital Moghasale from Seoul in the Republic of Korea. Vital is a research scientist at the Policy and Economic Research Center at the International Vaccine Institute in Seoul, and he leads a team of researchers conducting policy and economic studies to develop evidence for introducing new and improved vaccines for a range of diseases that include cholera, typhoid, and dengue. And Vital is going to talk today on oral cholera vaccines to control endemic disease and economic and epidemiological modeling analysis, and it's on page 6 of your abstract book. So please give a warm welcome to Vital. Vital.
Thank you very much for introduction. Thank you, Lancet, for selecting the abstract and inviting me to present here. So I'm going to talk about oral cholera vaccine, something what we call investment case, why to invest in oral cholera vaccine. So in this presentation, I'm going to talk what was the purpose and what is the disease burden of cholera worldwide, and what are the vaccination strategies we are proposing, and what is the vaccine demand, and what would be the supply available globally, and what would be the cost of vaccination if we needed to introduce in different developing countries where it's needed, and what is expected health impact, and is it cost effective to introduce vaccine. So the cholera investment case, whole set of studies was originally planned with an objective to provide evidence base for cholera, introduction of cholera vaccine in developing countries to control cholera as a part of broader strategy, because cholera is a waterborne disease. The water and sanitation is an important aspect, not only the vaccination. And the primary audiences for this research, evidence generation, is the global donors and decision makers, financiers like Gavi, WHO, UNICEF, World Bank, and then it's useful for the regional and national decision makers, and vaccine demand and supply demand forecast particularly would be useful for the vaccine manufacturers and new entrants to the vaccine production. So this is the first part of the study where we estimated where the cholera is located worldwide. This is based on the literature review. We identified 51 endemic countries which reported the cholera in some form in previous 3 years of the 5 years based on the WHO definition. And based on the literature review, because the cholera is generally seen in, the people at high risk are the people who have less access to water and sanitation. So we did the literature review of the studies, and the studies which were conducted in the high risk areas. And the whatever incidents we found, we extrapolated to the population at high risk in different countries, those who are identified as endemic countries. So in the map, you can see some countries are red, particularly a lot of them are Africa. They are the highest incidence per 1,000, the highest incidence countries worldwide. And based on this, we estimated around 3 million cases and around 100,000 deaths annually. And this was published in WHO Bulletin last year. Then what are the choices for vaccination? There are essentially 2 vaccines available in the public domain. One of these, which killed wholesale oral cholera vaccine with brand name as Shankol, that was recently pre-qualified in 2011. This is the last week, there was a publication in Lancet Infectious Disease which showed 65% efficacy of this vaccine over 5 years. When we did this analysis, we had the results for 3 years. And this vaccine was originally reformulated in International Vaccine Institute with the technology was subsequently transferred to developing country manufacturers in India, a pharmaceutical company named Shanta, which subsequently produced the vaccine and which was pre-qualified by WHO. Pre-qualification by WHO means it can be procured and used by most countries and also the UN organization like UNICEF. That was the main purpose. And there is a price agreement with them. They have to supply the manufacturers to supply the vaccine for less than $1.85 per dose, whereas the alternative available vaccine costs around $5 to $6. And this vaccine is easy to administer compared to the alternative vaccine, Dukoral, and also the longer efficacy, higher protection, and a longer duration of protection. So the analysis is based on we are introducing this new vaccine in the developing countries. So essentially we thought of 4 vaccination strategies. One is large target, the blue color left upper side box, and another one is small target. Large target means the urban slums and rural area without improved access to water. They are the highest risk. So whole population in the 33 endemic countries. And we either vaccinate children, that is the 1 to 4 years, or alternative strategies to vaccinate everyone above 1 year. This vaccine can be given to anyone above 1 year. And the small target is half of large target, because the large target is too big population. So that's why it will be very expensive to introduce to vaccine to a large population. So we had an alternative, a small target strategy. So, and the picture you are seeing, that's actually cholera vaccination happening in the government settings in India, in one of the states in India, Orissa. So then we projected, because this vaccine is not routinely used, which countries would introduce vaccine and when, based on a set of indicators like what is the past history of adoption of other vaccines, what is their capacity of immunization, such as what is the immunization cover for measles vaccine, coverage levels. So if they have higher coverage of routine vaccination, they are likely to use the vaccine earlier or likely to adopt it earlier. The same way, the other indicators are like if the countries have experience of doing surveillance of cholera, and what is the disease burden, an important factor. The higher the disease burden, they are likely to use the vaccine earlier. Based on that, the 33 countries we classified when they would introduce. The early introducers, the 11 countries we predicted to introduce between 2014 and 2017, the dark green colored countries. So different years, the different countries would introduce vaccine. Based on this information, there are 4 strategies. How much would be the global need of the vaccine, what global demand of the vaccine? So depending upon the strategy, size of the population, which countries introduce vaccine over the years, as you see from 2015 to 2030, the number of doses increases from 12 million to almost 200 million for the strategy showed here. There's a small target age group vaccinating everyone over 1 year. So depending upon the strategy, the number of doses required changes. Then we compared the vaccine demand with what is the existing capacity of the manufacturers so that we can find out what is the demand-supply mismatch, and if there is a need to produce more vaccines globally. If needed, the technology can be transferred to more manufacturers in the developing countries, or the existing manufacturers can produce more vaccines needed for the developing world. So the next step was to assess the health impact and of the vaccination, health and economic impact. For that, we have used a dynamic disease transmission model, which essentially the vaccines have a direct benefit that protects those who get the vaccination. Vaccine also have the indirect benefit. Sometimes those who did not get vaccine also get protected, the herd effect. So this is accounted in the model. So that was the original purpose. It accounts for the environmental transmission and transmission using between the human beings as well. And based on this model, we estimated what would be the number of cases averted by vaccination, by different strategy, by different countries, what would be the death that can be prevented, and then we converted that into DALYs using standard methodology. And also the health expenditures, the cost of illness, the treatment costs averted, we estimated using that. And then what would be when we know what is the program cost and the cost averted, what would be the cost per case averted, what would be the cost per death averted, and what would be the cost per DALY averted. We estimated using that. So here is a summary slide of one plus all vaccinating in 33 countries with the assumption vaccine is introduced around 2015, the green arrow you see. And the y-axis on the left side, it shows the cumulative cases averted, but on the right side, it shows the cumulative deaths averted over the year. And you can see that around between 8 to 18 million cases would be averted in 15 years if you introduce vaccine in that way. Also, between 250,000 to 600,000 deaths would be averted. That's the estimation. Then we looked at what would be the money needed for financing this vaccination program. So you can see 4 different colored bars with the number 2014 to 2013. There are 4 different strategies. So the earliest to start with in 2014, the lowest, the smallest strategy needs $15 million. But if we go to the biggest strategies by 2013, depending upon the strategy, the cost can go up to $750 million. That's the program cost of the vaccination. So the next step is to assess, is it cost effective to introduce vaccination in developing countries? So we use the standard definition. Cost per DALY averted is compared to the GDP per capita WHO threshold. If the cost per DALY averted is less than 1 time GDP per capita of the country or the region, that's considered highly cost-effective by standard definition. And if it's between 1 to 3 times GDP per capita, it's considered cost-effective. And if it's more than 3 times per DALY averted, it's not cost-effective. For example, GDP of Bangladesh is $1,500, if that's correct. If the cost per DALY averted is less than $1,500 in that country for cholera vaccination, that is considered cost-effective in that country. So any results, interventions, so you compare how much is the cost per DALY. For example, the yellow bar here shows it's 1.5 times the GDP per capita. That means it's cost-effective in that country. That's how we say that it's cost-effective or not. So looking at the cholera vaccination, will it be cost-effective? So on the y-axis, you would see the GDP per capita, and the x-axis, we have three different regions: African region, Eastern Mediterranean region, and Sierra region. So Sierra region. And I have the two strategies mentioned there, with the herd effect on the left side and without herd effect under each of these three bar. And with the herd effect means you don't account for the additional benefit of, with the herd effect means you account for the additional benefit, indirect benefit because of the vaccination. Without herd effect means you only include the direct effect. For example, if vaccine efficacy is 65%, so 65 people of the 100 would be prevented from cholera, just that effect. So when you include herd effect, the benefit is more. And the bars there, the blue bars, show what is the DALI, what is the cost per DALI. So if you look at the leftmost, the 1 to 14-year age group in African region, it costs $148 per DALI averted. And there is a red line which says very cost effective. That is the one-time GDP per capita threshold for that region. And the dotted line on the top there, it shows the cost effective threshold. So if the blue bars are below very cost effective lines, that means the intervention is very cost effective. And if it's below cost effective line, it is cost effective. So if you look at all the bars, most of the bars are below the very cost effective. That means they are less than 1 times GDP per capita, and all interventions are potentially cost effective. That's what the analysis shows. So in summary, the cholera burden is high in Africa and Asia, and the targeted program in 33 countries using oral killed whole cell bivalent vaccine would be, that's the current brand is Shankall, it can significantly reduce the disease burden of cholera, and it will be cost effective. And there is limited information on the disease burden available. There is the need of more information in many countries because cholera is underreported. And also the current vaccine is 2 doses. And if we have the 1-dose vaccine, if that's currently the clinical trials are underway, then it's likely to be more useful. So we needed to have that information. So after this analysis, this was completed in 2012. In 2013, the Gavi was evaluating 12 different vaccines, whether they should finance these vaccines for next 5 years for the poorest countries in the world. So the cholera was one of the vaccine included. They essentially they use the information based on this study, and also they worked with the International Vaccine Institute to develop more evidence as required for their analysis. So those results are expected in November or December, whether cholera vaccine would be supported by Gavi. So this includes a lot of experts from different parts of the world. There is a big list of people who have worked on this listed here. I am only a small part of this whole study. Thank you very much.
Thank you very much, Vital. What we'll do is actually we'll take a couple of questions after each presentation, as they are very different in topic. So please, over to you. Any questions for Vital? Anyone has a question? Well, let me start to ask a question, and you can all think of another one. Is there any room, though? You have presented this at a vaccine cost of $1.85 per dose. We know that there's, a large number of people living under $1 a day. Is there any room to drive this cost down further? And are there any sort of initiatives that attempt to do so?
Yeah, I think it's feasible to drive the vaccine cost down, and we have seen it happening for many other vaccines, and it's essentially possible for cholera. And as the volume of the demand goes up, the price goes down. In fact, in our analysis, the $1.85 price, we have assumed the cost would be coming down to $1.35 by 2018 when the vaccine demand goes up. But potentially, what we have seen is there are other manufacturers who are interested to produce the cholera vaccine when they are seeing the demand, particularly in last 2 years. This vaccine has been used in different places, including Haiti. Manufacturers coming and they are thinking potentially lower costs.
Thank you very much. Is there any other question from the audience by now? Yes, please. Can you come to the microphone? Thank you.
Hi. I have a number of interrelated questions concerning your topic. One is, do you know of any other studies, modeling studies like your one, concerning other poverty-related and neglected diseases and or vaccines for such diseases? And whether also another second question would be whether you think that your approach can be more generally applied for vaccines, also for vaccines which have not yet been developed, but which should ideally be developed for other diseases, and also whether your approach could be broadened, also not just to calculate the health benefits of new vaccines, but also more generally the economic benefits of new vaccines.
Okay. Thank you for the question. I think the investment case is the one of the common approach used for the vaccines, and for many other vaccines, to Rota, to pneumococcus, other vaccines, the investment case has been developed by different organizations. I don't remember. Recently I looked one analysis for one of the neglected tropical disease. I don't remember exactly how to recollect which was the one. But we are, IBI, we are working for developing a similar investment case for typhoid. There is a new vaccine for typhoid, the conjugate typhoid vaccine, which can be used in younger children. The current vaccine can be used only the school-age children. So the new conjugate, that's the current vaccine available, is the polysaccharide. But the conjugate vaccine, which can be used in younger age group, one of the vaccine was licensed last month in India. So that is a new vaccine. So we are doing a similar investment case analysis from disease burden to what would be the cost effectiveness. So we are doing that analysis. And there are other organizations like Swiss Tropical Institute. They are doing a couple of investment cases. The Gavi routinely does for their analysis. They have something called strategic demand forecast and investment case. So all the vaccine they are considering for financing, they do the analysis.
Great. Thank you very much again. And we hope to see many more data like the ones you've just described coming out in future World Health Summits. Thank you, Vital.
Thank you very much.
Let me now invite our next speaker. Dr. Hong Jiang is a lecturer in the Department of Maternal and Child Health Care, the School of Public Health, Fudan University in China. She got her PhD through a joint course at the School of Public Health, Fudan University, and the Tropical Medical School of Liverpool University in the UK. And her research interest is in maternal and child health care and effective services. Dr. Jiang Hong, please.
Thank you. Many thanks to Lancet and thanks to World Health Summit to give me this opportunity to present here. And I'm pleased to introduce our study to you. Now let's begin from the background. My study is about the mobile phone short message services on improving infant feeding practices. The low breastfeeding rate and the inappropriate infant feeding practices in China are of concern. In 2008, the exclusive breastfeeding rate for infants up to 5 months in urban China was only 16%. Other national data suggested that around 1/3 of babies were introduced to solids before 4 months. We know appropriate infant feeding practices have long-term effects on have long-term health effects. Now in Shanghai, babies are usually taken to community health centers every 1 to 2 months to receive regular routine child health care. However, due to resource issue, the child health care clinic is often very crowded, and parents could not get adequate communication and guidance from health professionals. In addition, research findings on improving early infant feeding are limited. In China, the ownership of mobile phone is high. In 2012, the majority of users were 18 to 40 years of age, including nearly all expectant and new mothers. On average, 1,200 messages were sent from each mobile. Mobile phone technology is increasingly used in healthcare services, health promotion, and disease prevention programs. In this way, it is known as mHealth. As one of mHealth's approaches, short message services presents a new channel for delivering information, allowing access at a time and place suitable to an individual and without high cost. Researchers have shown SMS intervention was effective in weight management and improving health services. But by now, there has no study comment on assess the effect of mobile phone short message services on improving infant feeding health. So we conducted a research to assess whether community-based short message service on infant feeding to expectant and first-time mothers could improve infant feeding practices in Shanghai, China. The duration of exclusive breastfeeding was set as a primary outcome. A study with a quasi-experimental design was carried out between December 2010 and October 2012. 4 communities were purposefully selected in 2 districts of Shanghai. In each district, 2 communities with a similar population size were selected, and one was assigned as an intervention group and another as a control site. Mothers were recruited when they attended the first-time prenatal care in the community health center, if they were eligible to the inclusion criteria. Mothers were followed up and checked for eligibility in the 2nd trimester. And finally, in the beginning of the 3rd trimester, totally 582 mothers were recruited, with 281 in the intervention group and 301 in the control group. The control group received only routine maternal and child health care. For the intervention group, in addition to the routine care, they also received SMS intervention. The intervention included a weekly message to mothers from the beginning of the 3rd trimester to 1 year postpartum. We also provide consultation from messages to mothers in the intervention group. Besides the weekly message, mothers also often received messages asking about their status of infant feeding practices. We set a message bank based on WHO infant feeding guideline, China residency diet guideline, needs assessment of mothers, and consultation with community health staff. And the different messages were tailored according to different status of infant feeding practices. The intervention was conducted computer-based and through two software which could be freely downloaded from the internet. Here we show the results. We just report the results at 12 months. First one is the primary outcome, exclusive breastfeeding duration. The median exclusive breastfeeding duration of the intervention group was 11.4 weeks, and it was 8.9 weeks in the control group with significantly statistical difference. Mothers in the intervention group were less likely to introduce complementary food before 4 months. There was no significant difference on the median time of any breastfeeding. Also, there was no significant difference on cup usage, bottle at bedtime, and the food for reward at 12 months between two groups. Discussion. The overall rate of exclusive breastfeeding rate reflected by our study was low, only about 6% in the control group, which could partly reflect the low exclusive breastfeeding situation in Shanghai. Although we detected the improvement on the duration of exclusive breastfeeding by the intervention, however, the effect size was relatively small. But we believe that from the population level, both in the China context and internationally, it could have public significance. Although we actively promoted introduction of solids to infants from the 6 months, however, mothers reported that some community health centers still advise them to introduce solids from 4 months. This could be an explanation of high proportion of mothers in our study who introduced solids from the 4 months. And we did not find the improvement on other specific infant feeding practices, such as cup usage, food for reward. We think this may be new concepts to Chinese mothers, and it might take some time to be adopted. Furthermore, this result suggested that the intervention dose might not be adequate to produce effect. Advantages of our study included that, as we know, it is the first community-based intervention study using short message services. And the intervention strategy aligned with the social application of modern telecommunication technology. The messages were evidence-based, relevant, and practical. And we sent different messages to mothers according to their different feeding practices, so the intervention was responsive. Limitations of our study included that the intervention group and the control group were not from the same community health center, so some bias could be derived from this design. Secondly, we have not explored the cost effectiveness of the intervention. Thirdly, because of high proportion of well-educated mothers recruited in our study, so the research findings would be limited by the generalizability. There is needs for further confirmation on early introduction of solids before 4 months because the rate of the solids before 4 months was relatively low in our research population. Conclusion from our study, SMS intervention seems to be effective in promoting exclusive breastfeeding at 6 months, effective in reducing introduction of solids before 4 months, but with limited effect in improving some other infant feeding practices. And there is needs for large-scale cluster randomized controlled trials in the future. That's my presentation. Thank you.
Thank you very much, Dr. Zhong. I would now also open the floor for questions, please. Yes, we've got a question there. Could you please also introduce yourself? Thank you.
My name is Klaus Fleck. I'm a medical journalist from Berlin. I have 3 questions. The first is, could you give an example for such an SMS? It's a short message, whether 3 or 4 sentences, and what did you tell in this, as an example, in these sentences? The second is, you said you had also consultation through messages. How did this work? How often did expecting mothers or young mothers respond to the SMS, and what did they ask you as the organizers? And the third one is, you said you had studied the cost effectiveness, but how costly was it actually, your service? How was it financed, and how costly is it? Was it very expensive or not?
Okay, yeah. Firstly, I will show you slides. Sorry. Yeah. Here is an example of message sending. Yeah, you can see the left side is a computer-based software, and we just input message here, and then click the send, and then the right side is a mobile phone. Mothers, they will receive our message on her mobile phone, and our message content. I can give you an example for. For example, in the 3rd trimester, we usually help mothers to get prepared for breastfeeding, and so we will, for example, the first message we will tell her the importance of the breastfeeding and the WHO recommendation on breastfeeding, including the duration of exclusive breastfeeding and the duration of breastfeeding. So every message is, we tailored around 180 words to 240 words. Because with this length, this message could be shown as a whole one in the mobile phone, not separated two like that. Yeah, and your second question is about
the consultation.
Oh yeah. Mothers they usually ask us, for example, her she felt her breast milk is not adequate, so what should she do? So we will give her some advice to absorb consistently and do not give up, something like that. And sometimes mothers, they will ask her questions about disease. For example, if she got fever, so they will ask us whether she could continue to breastfeeding like that. The third one.
The costs, your actual costs.
Yeah. Costs, yeah, I should tell you, because we use 2 software, and for the main one we used is for the most subscribers of China Mobile users. If we use this software, it is free to send messages to China Mobile users. These users, China Mobile users, accounted for around 80% of all mothers, and also in China, it is the first rank of subscribers. And for other corporate subscribers, we use a software called Front SMS Message. We downloaded from internet. So for this one, we should pay 10 cent RMB, China dollar. You see, it is just I will calculate just 1 cent to 2 cent US dollar for per message sending. So it's not cost very high. And for all mothers, the receiving message is free.
And your staff, doctors, nurses, to take care of this program?
We conduct this program in our school. Myself and our colleagues and our graduated students, they joined in this research, and we together send a message and or establish a message bank here.
Thank you very much. Yes, yeah.
Thank you.
Okay, one last question, please.
A very brief question, Peter Tinnemann from Charité University Medical Center. On your last slide, I noticed your study was funded by Nestlé, and Nestlé has been heavily criticized in the past for giving messages, in particular in low and middle income countries, of not breastfeeding, but using Nestlé products for infant feeding. Can you maybe comment on how you came to such a collaboration in your project and what the influence of the company was?
You mean, sorry? Nestlé Foundation, how can
the Nestlé company was in the past heavily criticized
for
giving different messages, in particular not in the direction of natural breastfeeding, but using instant food for toddlers and infants. And I wonder what the impact of the company collaboration with your study was and how it came about.
Actually, this Nestlé Foundation, it is totally separated from its cooperation, and I think officers in this foundation, they just assess our program from scientific way, and maybe our research findings will be helpful for them to their how to say, contribute to society. Yeah.
Okay, thank you very much, Dr. Zhong. Thank you again.
Thank you.
I would now like to invite our next presenter, and it's a great pleasure to have a fellow German presenting here, Peter van Philipsborn, because I think we have a lot to catch up here in Germany, and I'm saying that being a German national, so I'm allowed to say that, in terms of global health research. And it's a great pleasure to invite Peter van Philipsborn, who has a MSc in Global Politics from the London School of Economics and an MA in Politics, Economics and Law from the Albert Ludwig University in Freiburg, and he's doing medical studies at Ludwig Maximilian University in Munich, and he will present on the research and development expenditure for poverty-related and neglected diseases. Thank you very much, Philip, please. Peter van Philipsborn, please.
Good evening. Thank you very much for the introduction. In my presentation, I would like to talk, as you've heard, about poverty-related neglected diseases. More specifically, I would like to address the question whether definitions of these diseases can be based on solid quantitative data, and also how much data we actually have on such diseases. Now, on a very simple level, poverty-related neglected diseases are understood or are commonly defined as diseases which primarily affect poor people living in poor countries, in poor communities. That is, people who are poor on at least 3 levels: on the personal level, on the community level, on the national level. And examples which come to mind are diseases like malaria, tuberculosis, or also more rare diseases like Chagas disease or schistosomiasis. Now, it is commonly held that these diseases are not just poverty-related, but also neglected. Neglected, again, in several regards, and one of them is research and development. It is, of course, easy to understand why such poverty-related diseases could be neglected. Most patients are poor, too poor to pay for expensive new pharmaceuticals, And that's why private companies have little economic incentive to invest into the development of new medicines. Moreover, the public health systems of the worst affected countries are often underfunded and dysfunctional, and therefore unable to provide sufficient substitute for this lack of private funding. So there's a shortfall in R&D funding. Now, over the past years, there have been a number of major global health initiatives to address this problem. In January 2012, the London Declaration on Neglected Tropical Diseases was passed by the WHO and a number of other important actors in this field. Later that year, a consultative expert working group commissioned by the WHO presented a report on the topic recommending a binding international treaty on global health R&D, specifically focusing on poverty-related and neglected diseases. And on the last World Health Assembly, a resolution was passed on this topic, and currently negotiations are ongoing on such a possible international treaty. Now, with so much political attention given to this topic, we ask ourselves this question: well, can we base definitions of these diseases on really solid quantitative data? To address this question, we used the following data. Firstly, disease burden data, which we've taken from the Global Burden of Disease Study 2010, which was published as a special edition of The Lancet last year. And moreover, we used R&D expenditure data. We aggregated publicly available R&D expenditure data from public sources like UNESCO, Eurostat, and we also used disease-specific R&D expenditure data provided by GFinder. This is an initiative largely funded by the Bill and Melinda Gates Foundation. Now, we took this data to construct two metrics. The first one is a poverty relation factor. And this is actually a metric which was proposed by the WHO in a working paper last year. And we found this metric very useful to show how strongly different diseases are related to poverty. And that's why we decided to call it poverty relation factor. And this is a ratio of disease burden measured in disability-adjusted life years, DALYs, per 1,000 inhabitants in low and middle income countries, divided by DALYs per 100,000 inhabitants in high income countries. So it is a disease which is exactly as common in rich countries as in poor countries, will have a poverty relation factor of 1. And the diseases which are much more common in poor countries than in rich countries have large poverty relation factors, and the other way around. We also constructed a second metric, which is a neglect factor. It's again a ratio, this time the ratio of disease burden in DALYs as percentage of the total global disease burden, divided by R&D expenditure on the same disease as percentage of the total global health-related R&D expenditure. A disease which receives a smaller part of the global health-related R&D expenditure as it contributes to the global disease burden will have a high neglect factor and the other way around. The meaning of these factors will become clearer when we present the results. Now, we calculated the poverty relation factor for all 240 individual diseases which are included in the Global Burden of Disease study. And because this is such a large number, we decided to classify them according to the poverty relation factor into 5 groups. The first one, which corresponds largely to the type 3 diseases in the WHO framework, are strongly poverty-related diseases, or we decided to call them strongly poverty-related diseases. They have a poverty relation factor larger than 35. And here we found 28 diseases, and these are, with 2 exemptions, all infectious diseases. Then we found 54 moderately poverty-related diseases with a poverty relation factor between 3 and 35, and they make up about 1/3 of the global disease burden. And here we have also quite a lot of infectious diseases, but also most intentional and unintentional injuries, many maternal neonatal conditions, and also conditions related to malnutrition can be found in this category. And then there's a large group of diseases we found to be unrelated to economic development. There are 117 diseases being responsible for about half of the global disease burden. And in this group, most chronic diseases can be found, including cardiovascular and neuropsychiatric disorders. And then we also defined a group of moderately affluence-related diseases with a poverty relation factor between 0.3 and 0.6. There are 27 diseases which are responsible for about 10% of the global disease burden. And finally, some strongly affluence-related diseases. And here, these are mainly cancers and certain other chronic diseases. Now, in the second part of the analysis, you remember we compared these. Oh, okay, here you see all 240 diseases for which we calculated the poverty relation factor. And right in the middle, there are some diseases which have a poverty relation factor of 1.0. For example, liver cancer secondary to alcohol use, which seems to be exactly as common rich as in poor countries, asthma and major depressive disorder, just to give you an idea. Now, in the second part, we looked at disease burden and R&D spending. And here we found the total worldwide health-related R&D expenditure in 2010 was at $233 billion US. Now, when we looked at the disease-specific R&D expenditure data, which we've taken from GFinder, we looked at data for 26 poverty-related neglected diseases. And on these 26 diseases, $3.2 billion US were spent in the same year, which is about 1.4% of the global disease burden, of the global total amount spent on worldwide on health-related R&D. However, the same 26 diseases were responsible for about 14% of the global disease burden. So we see a big discrepancy, and based on this data, we could postulate a 1.414 gap in global health R&D, in analogy to the 1090 gap, which some of you might know, which is a term which has been for a long time used to illustrate imbalances in global health R&D, but which is not based on real figures, whereas our 1.414 gap is based on real solid data. But of course, it's not so catchy and not so impressive. But so now we also did this analysis for all 26 diseases separately, and this revealed interesting differences between the different diseases. And here we compare R&D expenditure and disease burden. And look, for example, here at HIV. HIV was responsible in 2010 for about 3% of the global disease burden, but only about 0.5% of global health-related R&D expenditure was spent on it, so it's a large shortfall. But then compare this to bacterial pneumonia and meningitis, which was responsible for 1.6% of the global disease burden, but only a tiny fraction of 0.04% of global health-related R&D was spent on it. And these differences are now depicted by this neglect factor, which we have constructed, which is actually the ratio between the two figures you see here. And here you have the same picture that you see for bacterial pneumonia and meningitis. This neglect factor is 37, whereas for HIV it is only 7. So HIV is neglected too, but much less, according to this metric, than certain other neglected diseases. And here, just to give you an idea, the neglect factor for all 26 diseases. The other picture was just some selected important ones. But our study has, of course, certain quite important limitations. First of all, the poverty relation factor captures only poverty relatedness on a country level, but it does not capture wealth and health disparities within countries. So there's diseases which are common among poor countries living in rather well-off countries. This kind of poverty relatedness is not captured by our approach. And as you know, wealth and health disparities within countries are enormous. So this is, of course, a major limitation of the poverty relation factor approach. all our R&D expenditure figures are lower bound estimates because we used only confirmed expenditure data, and this data, of course, is incomplete. And when looking at this neglect factor, also in general, when comparing disease burden and R&D expenditure, we have to keep in mind that the disease burden caused by one disease, by a certain disease, is of course only one of many different factors which should influence, which might influence the appropriate or desirable level of R&D on this disease. There are many economic, scientific, medical, political considerations which have to be taken into account. And this you have to bear in mind when you look at this neglect factor, and that's also why we abstain from defining on the basis of the neglect factor strongly or moderately or not neglected diseases, as we did with the poverty relation factor, which seems to us more straightforward methodologically as this possibility to define neglect. To conclude, we have found that there's a large shortfall in R&D funding for poverty-related diseases. This is a 1.414 gap, but with huge variations between individual diseases. Moreover, we have seen that poverty-related health problems are not limited to infectious, neglected diseases, but that also most injuries, malnutrition, maternal, neonatal conditions, also very important poverty-related health problems. And finally, we have seen that on the basis of our approach, poverty-related health problems still seem to be quantitatively, based on the disease burden data, more important than affluence-related conditions. We have defined 82 poverty-related conditions, which are responsible for about 40% of the global disease burden, but we have found only 43 affluence-related conditions, making up about 13% of the global disease burden. Some acknowledgements. I would like to thank Fridolin Steinbeiß, who actually did quite a large part of the work I presented here, as well as Max Bender and Aaron Vogt, who are, like Frido and me, also medical students at different universities here in Germany. And I also would like to thank Linus Grabenhenrich, and above all, Peter Tinnemann, who work as scientists here at Charité and who supported us a lot with advice and guidance. Thank you very much.
Thank you very much, Peter. Are there questions from the audience? Okay, I'll start with a question then. That's great, because I've actually got two questions, but I will start with one, and then I want one from the audience in between. So what about, did you, in your estimation of R&D expenditure, actually include implementation research? Because, you have examples here like rheumatic heart disease, and we know what to do with rheumatic heart disease. So, or was it strictly just research into new treatments? So could you perhaps expand on that a little bit?
The disease-specific R&D expenditure data which we have used is provided by GFinder, and this initiative funded by the Bill and Melinda Gates Foundation, and they have quite strict inclusion criteria. And as far as I know, they do not include implementation research, but only very strict pharmaceutical research aimed at the development really of new pharmaceuticals.
Thank you for that clarification. Are there questions? Okay, now then I'll ask my second question. What about diseases? And you might argue it's not a disease, but it's actually been classified as a disease now by the American Heart Association and others, obesity. So obesity, in some countries I would classify as a poverty-related disease, and in others as an affluence-related disease. How did you deal with that?
Well, obesity is not one of the diseases, of the conditions included as an individual disease in the Global Burden of Disease study. That's why we do not have results on it. But of course, one could do a similar analysis for obesity, and you could also do this separately for different regions. Whereas to do it on a national level, you would need a different approach, for example, taking data on different social groups in a society. But of course, this approach, comparing the delis per inhabitant in rich groups and in poor groups, this could be applied to other settings too.
And
so one
to answer
could,
your
but one
question,
had to distinguish nationally then differently. Thank you very much. Great, thank you.
Okay, let me introduce Trudy. Trudy Lang is a senior researcher in Oxford and has worked as a clinical trial methodologist in low and middle income countries for more than 15 years. Trudy started in the pharmaceutical industry, went to the non-profit sector, went to World Health Organization, went to University of Oxford, and now she's here with us. Please, Trudy. Trudy has sent an abstract with the title, "Can we change research to change health?" And this is an important question. And the first thing Trudy did is to change the title of her abstract. So the title now is Sharing Methods for Global Health Research, an Assessment of Methodology. And you might feel as you are the last speaker of this whole event, but you might be the most important speaker of this event. So please, Trudy.
No pressure there at all, then. Thank you very much. And thank you very much to The Lancet and for the organisers for inviting me to speak. I do hope in some way I can pull together lots of what we've heard this afternoon. And I do agree, it cross-cuts lots of topics, and I should try and pull that together. So what I want to talk to you about this evening is some work we've done with a very wide collaboration of people, far too many to list, and it's absolutely a collaborative activity, where we've recognised the need that we've all got to do something a bit differently about how we work. And so we set up a mechanism, we hoped, to see whether we could really change the way we as scientists behave and how we approach how we do research. And really, the overall objective was to see whether we can streamline and speed up research in the most neglected areas in the world and where the most research is needed, which is very nice following on from all the talks we've heard today, because these are exactly the sorts of things we need to encourage. So, of course, we all know that we need more data, and I was very grateful to Richard Horton's introduction of this session to talk about the need for more data, because indeed we do. And I think what we come across a lot in our work is that there's a lot of confusion about what clinical research is and what the acquisition of data is all about. There's a perception, especially in low-income countries, that clinical research is all about shiny, shiny clinical trials, where perhaps I often call them helicopter trials, whereas a clinical trial is being planned for drug or vaccine registration, and it's all set up overseas, and the protocol arrives in the developing country, and the drug or vaccine trial happens, and the data is collected, and off it goes back to the pharmaceutical company or the charity or the product development organisation to facilitate a drug or a vaccine registration. Now, we absolutely need those clinical trials. There's no question. We've heard about the vaccine initiatives today, which are fantastic. I've spent a lot of my career doing malaria drug and vaccine trials, and they're critical for increasing the research capacity, but obviously also developing the products that they're all about. But clinical research is a much, much broader spectrum, and we need the whole diversity of research. I was delighted to hear the first talk earlier about doing the mobile phone text messaging studies in China. We've been involved in lots of those in Africa as well. And it's this sort of pragmatic research that is about, often about disease management and how to improve processes. It might be about training nurses in a different way, or healthcare workers, to look at what they do every day in their practices and change what they do. So there's an awful lot that can be gained from evidence, and it's often simple, pragmatic research that can bring the biggest benefits to research, and there's just not enough of these types of studies. The poor and the vulnerable are drastically underrepresented in research, and there's a myriad of reasons for that. It's all about increasing equity to access to research, and I mean that in the broadest sense of giving everybody the chance to take part in research, be they the participants or the researchers themselves, and then giving access to the advantages of having the data, so evidence to drive change, which I'm sure has been touched on a lot over the last couple of days. And what we've been trying to think about with this large collaborative activity we've been working on is changing researchers' behaviour to make that happen. So there's many barriers to research in low-income settings. The perception about research, as I described earlier, many people perceive research as being something that foreigners have to do, that comes in from the outside. They think it's expensive, and they think it's difficult, and they think it's not for them. And this is a sort of self-perpetuating myth that leads to lack of research skills, awareness, and really the confidence to undertake research and embark upon it themselves and do this type of pragmatic research we've heard about this afternoon, and I'm sure elsewhere across the last couple of days. Populations are hard to access, and it's really difficult to do research in the hardest to access people. And the photograph on this slide is a podiokinesis clinical trial that's going on in Ethiopia at the moment. A very pragmatic trial trying to improve health outcomes for these desperately neglected communities up in these regions. You know, people find it difficult to access healthcare. And, you know, in Kenya, 70% of people die in the community. They never even reach the hospital. So research needs to happen where the health burdens exist. And it's not just training for people to do research, but the whole spectrum of research support within the health systems, also right through to things like regulatory support and ethics capacity to make sure research is appropriate and ethical for those situations. So in our experience in many years of supporting clinical research in developing countries and thinking about capacity development, there's a sort of blindingly obvious fact that I think people miss, that most things we do in research are the same. And it doesn't matter if it's a clinical trial of a cutting-edge vaccine or even down to a pragmatic observational trial on a hospital ward. Many of the things we do are the same, and the things we find difficult are the same. And what we've been doing on the ground for many, many years is training people in these steps and asking people to share what they do. As a scientific community, in the broadest possible sense, we've got a lot better at sharing data and talking about sharing data, but we're not very good at sharing methods. And as scientists, we're brought up to compete. We learnt that we won the opportunity to speak today, which is fantastic. We compete for publications, we compete for funding, we compete for everything we do in science. And so we're not really encouraged to share by the very environment in which we work. But if we did share what we do and how we do it, we could speed up what we do, and that was our hypothesis for this project, really. And if we did share how we do research, then we'd have things like better data dictionaries, we'd have standard terms, we'd agree endpoints, all those things that we need to do before we set about our research. And lots of things that we all have to tackle, research laboratory issues, data management, setting up consent systems, community engagements, all the things people struggle with their research. Everybody tends to reinvent the wheel and just solve these same problems over and over and over again. And we suggest if people talked about what they've done and shared their tools and methods, then the next lot of people coming along, it would be much faster for them to set up a study and they could progress much quicker. And it would raise standards. People share what works. And so we decided to use a digital solution for this on the basis that this is being exploited in the rest of the world, isn't it? I mean, everybody's, this meeting is making great advantages with Twitter and Facebook and LinkedIn and all the social media everybody uses. Everybody shops on Amazon or checks out hotels on TripAdvisor, but we're really not exploiting this sharing phenomena in science as yet. And really this is what we've set out to see if will work with this project. So we set up something about 2 years ago called the Global Health Network. And the simple concept was an online science park, really, a space, a shared, neutral and democratic space where people could simply share what they've done and how they work, or ask for help, share protocols, share methods, share templates. And the idea was that you could have people to connect together to simply share their methods and exchange their experiences in order to speed up and improve research. So the Global Health Network is this online forum that we set up, and within it we've had an ongoing sort of iterative process of measuring what we do, asking what people think, trying to assess whether it's working and what the uptake has been. And this is really what I'm presenting today. So the idea was to have member areas where people, if you like, have their own building within the science park to talk about dengue research or maternal health or diagnostics, whatever it might be. And then there's cross-cutting areas to support people, maybe laboratory help, data management, how to set up a clinical trial, statistics, all those sorts of cross-cutting things that tend to replicate whatever you happen to be working on. And then we've got particular research tools to help people with what they're trying to do. It might be a process map to guide them, perhaps an e-learning course, but all sorts of things you may need. And this is all still an early starting point of a concept, and this is evolving all the time. But what we've set out to do as we've done this is ask people if this works. Are you willing to share? Is it working for you? What do you want on here? What are your knowledge gaps? And so this is what we're now trying to pull together and see if it is working, and if indeed we can get researchers to change their behaviour and share what they do. So I'll just give you a few examples of what's going on the network right now and some of the feedback and some of the data that we've gathered on how it's being used. This is an example of a member area on the Global Health Network. So on the Science Park analogy, this would be a building or a floor in the science park. And this is a network between several universities and the WHO that looks at flu epidemiology, seroepidemiology. And what they are simply trying to say is that there needs to be shared protocols, shared protocol developments, shared agreed standards. And if there's a flu outbreak anywhere in the world, people need to be able to take a protocol that doesn't belong to anybody per se and run with that protocol and use it in their region and get some data. It's all about getting data. Now, disease outbreaks are notorious for having a complete dearth of research because it typically takes so long to set up a study. So this group are sharing their protocols and putting them out there for people to download. So this is working very nicely already, and you can see there's protocols up there that anybody can use and set up in their own regions. Another area which refers back nicely to the talk we've just heard about trying to support mothers and how babies are fed. This is the mother-child link area. Now, this is quite a large organisation of people from very different networks that are trying to come together and have a neutral democratic space for maternal health research. So there's several different groups organising it, and the point is that there's so many different groups otherwise that are maybe based in one region of the world or one organisation or one institution, but they want to create this sort of sense of a democratic, shared and neutral space. So they come here and say, oh, look, this is what we're doing in neonatal care, or this is what we're doing in measuring fetal outcomes, and just offer their experiences and their templates and their tools. The global health trials area was one area of the network that really set this up. This was created as a space where people could share how they run clinical trials. And the idea was to encourage really diverse clinical trials. So as well as the regulatory trials, but, looking at drugs and vaccines in the typical sense people often experience trials, but right through to the spectrum of comparing two different ways of approaching caring for neonates in hospital, or pneumonia care at home and inpatient care. And the global health trials area is the busiest area on the network, and there's hundreds of discussion threads on all sorts of topics, from community engagement to how to set up a database. And that's one of our most successful areas so far. So just to give you some data on how it's all going, we've had over 150,000 people now use the platform, and over half the people that come along and have a look at it come back, so they are finding it useful. What we've been really pleased to see is that one of the whole aims of this was to go beyond the sort of principal investigator and the clinicians, but really access people who are at the front line. So the people that work in the laboratories, the maternal health care workers, community health workers, clinical officers, and also the sort of broader people that need to be involved in research, such as regulators, research coordinators, and so on. And it really is being reached by those people, because digital technology is the way ahead, and as we've heard already today, people have mobile phones and access to internet all the time now in their roles, and this is the best way to reach people. And we are seeing this uptake. Most of the use comes from developing countries. Everything's built to work on a low bandwidth, and it seems to be being taken up quite well. Growth and uptake has grown month on month, and we're about having between 7,000 and 8,000 people visit the platform every month. And inbuilt across the whole thing is a system of trying to find out if this is really being useful to people, and if they are interested in sharing data and what their thoughts and perceptions are. And we do this through surveys, but we also run workshops in the regions, and we talk to people and ask them what they need and what they want to see. And we've also done some particular work doing more focus group discussions and in-depth interviews. And the feedback is excellent and is very reassuring. And people want to share, they're keen to share, they value what they're finding on the platform, and things like e-learning in particular seem to be very popular. But this is definitely early days still, and we're just setting out on this, and we've still got to move forward, and I think we've proved the fact that people want to share and they're keen to do this, and I understand it's a necessary next step. What we've yet to do now is prove that it's speeding up research, and actually people are doing more studies, but that's in the next plan, really. So to summarise, we went ahead to try and find a mechanism to help people speed up and facilitate better and more research in difficult-to-work places in the world where there's a lack of research, by providing a neutral and democratic space without geographical, institutional, financial barriers. And so far, over 20 different research networks have joined in on this and are sharing their methods and developing their research ideas and building collaborations. So it operates like an online science park, and the idea is to provide cross-cutting tools and support. It's seen, and with the feedback that we're getting, is it is indeed seen as a neutral and democratic space, and the numbers of visitors and uptake of the platform have supported this. Over 5,500 people have taken the digital learning courses now, and there's tens of thousands of examples of people sharing particular pieces of information and gaining information to help them drive their studies forward. And it is important because there's such a dearth of data, as we've heard from earlier talks, in particular areas of the world. And face-to-face training, workshops, activities on the ground and local networks are essential. But to do things like speed up research in rare diseases where you need large numbers of people recruited into studies, or for people to collaborate to make it happen faster, people need to be able to access each other and to find people to work with, and also hopefully develop things like protocols and case record forms and data standards in an open and collaborative way. And this is really about changing the paradigm of research. You know, protocols are normally developed in closed spaces, not shared. They're owned by the individual investigators. And this sort of hypothesis is to really speed up research, especially in things like rare diseases and disease outbreaks. We need to have open access protocols that nobody owns, but people can still benefit in the same way they usually would from their publications and getting funding for doing this work. And if we can prove to people that this does make it all happen faster and better, then they'll buy into it and it can happen. But it only does this because, in fact, most of the steps and processes of using research are the same, so it can work by speeding it up, and it should be an iterative process. The reason we think this is particularly innovative and why it's timely to do it is that we're going this extra step and harnessing digital technology, and this is where we feel it hasn't really happened so far. And you know, the commercial world is well ahead of the game, and everybody's involved in all these different platforms and resources online. We all do our shopping and buy our books, and we're not really harnessing this yet for global health, and we should be. And by doing it in this way, we've brought the cost down because it means that people can access this cutting-edge digital technology you know, virtually for free, because the infrastructure costs have been paid centrally by this global health network. And so we're using this, what's called, you know, the sort of sharing generation that people are talking about, to the advantage of global health. So we're providing this nice sort of mixture of access to experts and a community, whilst harnessing the latest digital technology to do so. So this is all based on a theory, and you know, we think so far we've shown that indeed scientists are willing to share, and this could be a good mechanism for us and others to do this by working online and creating the space and opportunity for people to do this. But it doesn't need to be limited to an online platform. This is really about what I set in the title, about changing researchers to change health, changing practice and changing the way we work, and just getting people to see that it does work to operate in collaborations, share knowledge, exchange tools and resources. And the community of practice theory is something that's, you know, been around for a very long time and was coined by people who make photocopiers, really, and they showed that they could have these really expensive training courses, ship people across the world to go to these huge seminars to teach them about how to fix a photocopier, when in fact the most effective way was one photocopier repairman standing in front of the photocopier with his colleague and just saying, actually, you know, it's not page 32, just, you know, tweak this bit here and turn this screw here, and that's how it works. So we're using community practice in this setting by having a research nurse in Nepal tell a research nurse in Malawi how she set up a community advisory board or how she developed a consent form. And it's having this ability for people who are experiencing a problem share with each other how they solve it in order to move forward. So we believe it is possible to set up communities of practice to improve research outcomes and to raise standards and speed up research. But we've just got to go the next step now and really, make this much more accepted and the norm, and see if it can indeed result in more data to drive health outcomes. Thank you very much.
Thank you very much. Thank you very much, Trudy, for sharing your knowledge and your research. And are there any questions for Trudy? Rupa, please. Please take the microphone and then mention your name first, please.
I'm Rupa. I just want to say it's really a fabulous work that you guys are doing, truly inspirational. I wanted to ask a little bit about what challenges have you encountered, and what are some things for people that do support the work you're doing that we could potentially do to support it more?
Thank you. That's really helpful. Yeah, I think the biggest challenge is getting people to contribute. There's this, I come from a background of running clinical trials in developing countries. This whole business of using digital technology and working online is as new to me as it is to all of us, which I think is why it's working, because we don't really know what we're doing, but we find these clever people that do. The biggest challenge is getting people to contribute. So everybody says, this is a brilliant idea, this is fantastic. And what we find is that this is sort of the old 90-10 rule. In fact, it's 99-1 rule in this, what happens in sharing communities of practice online, is you'll have 100 people read something and only one person will contribute, because we're all busy people. So everybody says, yes, this is brilliant, I want to set up an area for diagnostics or maternal health or oncology. And we know that people are coming on and reading what they want and then going, which is great. We've given them the information they need, but then they're not coming back and saying, actually, this is what happened for me. So the biggest challenge is just getting people to share what they've done. So I'm going to be contacting people after this meeting, because I've seen some fantastic stuff this week, and saying, please, will you share that with everybody else? And everybody says, yeah, of course I will. And then it takes a lot of nagging to get people to do it. So that's definitely the biggest challenge. And it's more a question of people's time than lack of enthusiasm. But that's the hardest bit, for sure.
Okay, thank you very much, Trudy. As the time is already a bit over, I think if you have any additional questions to her or the other speakers, we might have a last drink outside here. Thank you to all speakers. Thank you, Trudy, first. Special applause, please, for Trudy. So, thanks to all the new voices in global health that we have heard today and also during the poster sessions. And a special thank you to Majdi Ashur, who might have been able to at least watch the live stream of his presentation by Richard here. Even though we are in the Federal Foreign Office and we get the full support from the Federal Foreign Office, it was not possible that he could cross the border from the Gaza Strip to be here. So hopefully he at least has been able to watch the live stream. Thank you also to the German Ministry of Health. I want to mention them in particular because the German Minister of Health presented the first global health concept at the beginning of this conference. And it's the first time in the German history that such a concept was actually delivered and launched here. And although we have a new government pretty soon, we do hope that the new government will take over this concept. So Germany, in a way, is also now a new voice in global health, like you guys. So please keep the global health concept of Germany on your agenda and remind the German government that they have it in their drawers and that they can make much more out of it. Thanks to The Lancet, to Sabine and Richard for co-organizing or mainly organizing this whole abstract submission project, and we do hope to continue in the future, so we'll be able to listen to even more new voices. I would also thank all the participants of the summit and all those who might already have left, but they were here, so they are part of the World Health Summit movement, I might want to call it now, because as you might have seen, we have been to Singapore, we're going to Sao Paulo and to Kyoto in 2015. So it's not only a conference here what we are trying to organize. I think by the participation and by your active contribution, it has become like a World Health movement in a way, where multiple sectors can come together to discuss, and we still have to work on our outcomes, that they are more clear, that people more understand what we are doing. But as you mentioned before, the networking factor, that you meet a lot of different people, exchange ideas, exchange research results, and exchange business cards, of course, is so important. And that's a factor that might not be in any publication, but to see all these inspiring people here makes me even work more hard next year to give you a better slot in the program. So the new voices are not the last ones to present, but maybe the first ones to present. And to make it short and to give our technicians the opportunity to go home sometime, I would like to thank you all people who have been involved around our World Health Summit team. And on behalf of the M8 Alliance, the Charité, our World Health Summit team, I wish you a safe travel back home, and I hope to see you again next year in Sao Paulo and in Berlin. Thank you very much.